This is the first exam for cardio. It's gonna be on A&P, diagnostic tests and assessment. So like, how would you assess? How do you take an apical pulse?
A&P what? 6 and 7?
Well, no, how do you take it? Yeah, where do you assess an apical pulse? Okay, so we have the
It's a middle clavicle, fifth intercostal.
inner space, yeah.
So it's A&P assessment, and what was the other one that you said? Diagnostic.
Yeah, diagnostic tests. So my advice, folks, is to quiet down, to take out a sheet of paper, and to take notes in the topics that I'm going to be discussing right now. I know, it's not really. Sorry. Is the back really hot too?
Yeah, it's really hot.
No.
Yes.
I'm gonna see if I can bring it down next to it. It's nice and cool in that room. All right, so you folks ready? All right. When it comes to the heart, what's considered the pacemaker of the heart?
AB valve.
C note.
The SA nodes. The SA nodes.
Okay.
The SA nodes. The sinoatrial nodes. You guys remember that, right? Sort of. Sort of a little bit. Okay. Do you folks remember what preload and afterload is? Okay, let me explain what preload and afterload is real quick. Okay. Preload is how much pressure is filling the heart up because of the pressure of the blood going inside. Okay. So in other words, if the preload is fast, it's really high, then the afterload is going to be high as well, right? Also, if the preload is high, meaning the force of the blood going into the heart is high, it's doing what to the heart? It's making it work harder. So just understand that concept. The afterload is the pressure inside the blood vessels after the blood is leaving the heart. Okay, so if that doesn't make too much sense right now, write down preload, afterload, and make sure you guys read about it. Miss Lee will talk about all this stuff tomorrow, and if she's not here, I'll talk about it again tomorrow.
Well, we're only here till 11:30 tomorrow, right? Because we have to go to West Covina.
Like I said, I don't know.
Oh, right.
I don't know. I didn't know that. Tomorrow's free dress day.
Yeah.
And they told me all these other things. They haven't mentioned anything about that, unfortunately. I'm sorry, guys. I don't have enough information about that, but I'll find out. Okay.
Kill Bill.
Huh?
Isn't that from
Kill Bill.
what's that movie? No, the other one, Jeepers Creepers. Right?
It's
No.
Kill Bill.
Okay. Anyway.
On YouTube.
Let's see.
Our first exam's next week.
Your first exam will probably be next week, yeah. Next week. Next week. Yeah, next week. You folks remember that when a patient has heart failure, the pumps aren't functioning adequately, right? What happens when the patient lies flat?
It starts to pull.
It starts to pull, right? And it starts to back up. Depending on what side of the heart is failing, it starts to back up. Usually it backs up into the lungs, and in particular if the left side of the heart is failing, right? So what's that called when the patient can't breathe because of that? Dyspnea is just difficulty breathing. You guys remember with orthostatic?
Oh, yeah.
Or I'm sorry, not orthostatic, but orthopnea?
Yeah.
Okay, the inability to breathe when you're laying flat. Okay? There's also something called paroxysmal nocturnal dyspnea. Now this I haven't talked about yet. This is,
Can you spell it?
you know what? Let me go get a marker, guys. I'm sorry. Let me go get a
Just spell it
marker.
for us, so you know what
Okay. Paroxysmal. That's paroxysmal. Nocturnal. Okay, Nocturnal. Nocturnal. Dyspnea, dyspnea. So paroxysmal nocturnal dyspnea, folks, is worse than orthopnea. Okay, it's worse than orthopnea because the paroxysmal nocturnal dyspnea, when does it happen, do you think, based on that word? At nighttime. So it's so bad that it'll wake the patient up. It'll wake the patient up because somewhere throughout the nighttime, the heart isn't pumping as effectively, so all the fluid starts backing up, and the patient feels like they're drowning. Okay, so that's paroxysmal nocturnal dyspnea. If a patient, first of all, when somebody has chest pain, what's it called? Angina, right? Angina or angina, however you want to pronounce it. What causes angina?
Stress.
Okay, that physiologically what happens to the heart when there's angina?
The arteries are blocked.
Inadequate blood supply to the tissue because the arteries, the coronary arteries, aren't supplying the myocardium, right? The actual heart tissue. So it causes something called ischemia. You folks remember what ischemia is? It's ischemia. Ischemia is a fancy word that we use when we're describing when there's not enough oxygen going to the tissue. So it causes angina, it causes chest pain. Okay, but it's only temporary. What usually solves angina?
Nitroglycerin.
Okay, but before we give nitroglycerin, what else? No medication. What resolves angina?
Oxygen.
Deep breathing.
Okay, no medication, no oxygen, no nothing.
Deep breathing.
Breathing.
No. Usually rest. Rest. Usually angina. Oh, yes.
Can you spell one more time?
Which one? Yeah. Ischemia. That's ischemia. Usually when a patient has poor circulation, particularly to the coronary arteries, folks, the patient starts running. Like yesterday, we went to we celebrated my daughter's birthday, and they all decided to play like dodgeball, I guess, or dodgeball, baseball, kickball, whatever it's called. And I'm like, oh no. So anyway, so I played it, and that's why I'm all tired and sore. But anyway, I was surprised that I didn't get angina because it usually manifests during periods of physical exertion. Okay, but when you have angina, it's temporary, meaning the arteries are clogged, but not all the way. Okay, so it's just temporary. So usually if you stop and you rest, usually that does it. If that doesn't work, you give nitroglycerin. Nitroglycerin is a medication that we give, and it dilates the blood vessels, so it increases the amount of blood flow to the particular tissue. Does that make sense? Okay. What position do you think would be favorable to put a patient that has angina in?
Semi-foul?
Yeah, like a Fowler, semi-Fowler's position, right? Okay, good. There's something called cardiac catheterization. Write down cardiac catheterization. This is something that you guys are going to be talking about tomorrow. It's something very simple that we do to patients that have atherosclerosis or arteriosclerosis, right? The hardening of the blood vessels and the blocking of the lumen or the actual tube of the blood vessel because of all that plaque. So what we do is sometimes we catheterize the patient through the femoral artery, and we put a little tube that goes all the way up, and eventually we put it all the way inside the blood vessels that are clotted. And usually at the tip there's a little balloon, we inflate it, and we keep the patency of the blood vessel. That's cardiac catheterization.
To keep the blood vessel open.
To keep the blood vessel open. It's less invasive because before, what do you think we had to do? Open heart surgery. Okay, now all we do is put a catheter through the femoral artery, and that's how we actually do it. What do you think is a complication of that? Bleeding. Bleeding is a big complication. Infection, yeah. But folks, when it comes to infection and bleeding, which one comes first?
Bleeding.
Bleeding, yeah. Bleeding comes first. I want you guys to read up on cardiac catheterization as to like what are the teachings. What do we do? Can we walk right after that?
No.
Okay, we usually shouldn't be walking after that. You want to make sure that the patient's not bending their knee. Okay, so if you're going to reposition them, how do you what's that term that we use to reposition a patient? Log rolling. Does that make sense though? Because we don't want to bend this particular leg right now, this angle right here on the femoral artery. Does that make sense? All right. There's something called central venous pressure. Central venous pressure. Okay, I want you guys to think about the inferior and the superior vena cava right now. You guys remember what those are, right? Do you think if the right side of the heart is failing, it's going to be backing up, right, into the superior and inferior vena cava? Is the pressure rising or lowering? Rising, right? So too much pressure is bad. All right, okay, that's all. I just want you guys to understand that concept first. So again, what causes that central venous pressure to go up that I just talked about?
The backing up of the blood flow.
The backing up, right? But what causes that backing up? Heart failure. Heart failure. Heart failure. You folks remember the different layers of the heart? Okay, I want you guys to. We have the epi or the pericardium, which is the outermost portion. Okay, the myocardium, okay, and then the endocardium. The endocardium is inside. Okay, then we have the visceral, the parietal layer, the fibrous layers. Okay, yeah, I just want you guys to remember those. Mr. Lee's going to talk about those again. I talked about the epicardium, right, or the outermost layer. You folks remember the pericardial sac? Okay, it surrounds the heart. Remember, what's the purpose of that? It protects the heart. It protects the heart. Yeah, maybe for friction and all that. Yeah. Yeah, it protects the heart, prevents friction. Protects the heart, it prevents friction. When it comes to the blood vessels, you folks know what type of tissue they're made out of? Not cartilage. Cartilage is more like bones and joints. Connective tissue and one more. Muscle. Muscles and connective tissue. Arteries, folks, have the ability to contract, okay? And they push that blood through. So usually blood vessels are composed of connective tissue, okay, and also muscle. And do we have control when we flex our arteries or the blood vessels, I mean? So do you think it's smooth or it's smooth muscle? Because smooth muscle is involuntary, meaning it does it on its own. Yes.
Can you explain one more time proximal non-radial system?
Yeah. Paradoxismal. So essentially when a patient's lying flat, okay, your heart's pumping blood, right? Your heart's pumping blood everywhere, all over your body. So when you have some type of heart failure, your heart is not pumping enough blood into the different areas, in particular the lungs, right? So if let's say you're left-sided heart failure, right? The left side of your heart is failing. So that's not pumping blood out, okay, to the rest of the body, then it's gonna be backing up, okay, backing up into the lungs, and then when it backs up into the lungs, it starts backing up into the heart, and that's called, you feel like you're suffocating and you're drowning. So that's when you wake up in the middle of the night. It's something that happens when you have paroxysmal nocturnal dyspnea. That's just what it's called. Can you guys tell me what a pericardial friction rub would be? Yeah, so we talk about the pericardium, the sac that surrounds the heart. Okay, it's when it becomes infected. Okay, it becomes a little bit inflamed, and now there's a rub in there. You can actually hear it when you auscultate it. So that's what a pericardial friction rub is. It's when it's inflamed. The pericardial sac is inflamed.
When the fluid is.
There's fluid inside. Actually, it could be a heart attack, and now there's no fluid inside because of the tissue. So now it irritates the actual pericardium and the epicardium, and there's that rub. It's usually there's an inflammation, or there's death to the tissue, and it causes that friction rub. So I just talked about what can cause a pericardial friction rub. Heart attack, yeah, myocardial infarction, yeah, that usually can cause it. Because if you think about the sac that surrounds the heart, if there's death to the tissue, is there going to be any fluid building up inside the pericardial sac to keep that lubrication? No, because that tissue's dead now. The cells that are responsible for releasing that fluid are gone. So that's why that might cause pericardial friction. When a patient's having a femoral catheterization, folks, what type of complications can we have that are not infection, it's not bleeding? What else?
Perforation.
Perforation, so we could like sever the artery, right? If we sever the artery, or if the artery ruptures, what's not going to go to the distal end of that leg? Blood. So how can you assess if you still have an intact artery? Pedal pulses, the pulses, so you assess the pulses. Good. You folks know what a Holter monitor is?
Yeah.
Okay, write down Holter monitor.
Oh.
Holter. Holter monitor.
It's a running EKG.
Yeah, it's a running EKG. Yeah, just what Susan said. So essentially, if you guys ever felt like you had a your heart skip a beat or something, well, sometimes when it happens chronically, and you're nowhere around an EKG machine to see what it is, the doctor will recommend for you to have a Holter monitor. So it looks like a purse, a little man purse, and it's got the leads hooked up to you. So throughout the day, it's got a little computer inside, and it monitors your cardiac rhythms. So what ends up happening is it has a date and the time, and of course, when you go back to the doctor, it says, well, you usually stress out a lot between 9 and 3 p.m., Mr. Hernandez, every day. What's going on during 9 and 3 p.m. every day? Well, I have this PO14 class, and then come to the weeks that I no longer teach it, I no longer have any cardiac arrhythmias, so you guys are the problem. But essentially, that's what they do. And sometimes stress does cause arrhythmias, but just understand the purpose of it is to assess.
On it too, that like if you feel intestines, you can push the button and it highlights it.
And it highlights that particular one. Yeah, that's true as well.
So to assess what?
To assess cardiac rhythms. And Ms. Lee's going to be talking about like what can you do, like can you take a shower while you have a Holter monitor? No, like you can probably take some type of sponge bath, or or if the doctor says that you can take it off, but she probably won't, then that's going to be something you can do. You folks remember the difference between your LDLs and your HDLs?
Yes.
Okay, low density lipoproteins are bad. High density lipoproteins or HDLs are good. These are cholesterols. They're different types of cholesterols. The HDLs, guys, the high density lipoproteins, they're good because they maintain the type of cholesterol that gets stuck in your arteries. It maintains them. It keeps them low. It actually keeps them from not sticking into the inside of the lumen of the blood vessel. Your LDLs, the low density lipoproteins, are bad because they clump up and they cause angina. Okay, so there's the difference between your LDLs and your HDLs. What's the difference between a modifiable and a non-modifiable risk factor dealing with cardiac? So age is modifiable or non-modifiable?
Non-modifiable.
Non, and then smoking would be modifiable. Okay, good. What's the purpose of if sometimes folks during surgery or after surgery, or even a patient that's going to be bed rest for a long time, we put those elastic stockings on them, Okay, you guys know what the purpose of that is? To prevent DVT. So how do you know, but they're pretty tight, how do you know how can you assess to see if they're too tight or too loose?
The
Capillary refill.
Capillary refill. Yeah, that's right. That's why you want to use the ones that have the hole in the toes. Okay, you assess capillary refill, you assess the color, you assess the warmth. Okay. So if I have high LDLs and low HDLs, is that good or bad? Bad, because the LDLs, which are they're high, those are the bad ones, and the HDLs, they're low, and those are the good ones. So you want to have more HDLs than LDLs. What's the middle layer of the heart muscle called? Myocardium. Okay, good. You folks remember the pericardial sac again, right? When you look at the pericardial sac, I always talked about the visceral and the parietal layer, right? You have one more layer to that. The outermost layer that actually anchors the heart into the mediastinum. You folks remember what the mediastinum is? It's that hole right here, right? The space where the heart's at.
Where
So
all the arteries going.
with all the exactly. So the heart's there, and you wonder what keeps it there. Like if you turn this way, why doesn't it go towards the side? Well, you have a fibrous connective tissue that connects it to the wall of the pericardial of the mediastinum. So you will have the visceral, okay, the parietal, and then you'll have the fibrous. Does that make sense? Before I only talked about two of them, the visceral and the parietal. You folks remember those two? Now you have another one you're adding on top of that. So which one anchors the heart to the mediastinum? The fibrous. Okay, good. Good. The fibrous. 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 Now think about this real quick, guys. I talk about fluid inside the pericardial cavity, right? The pericardium that reduces friction, that fluid. We have two types of fluids, serous and mucus. Which one do you think is inside? Serious. Good, good. Why is it not mucus? Because where's usually mucus found? And the GI and the airway, anything that usually leads to an outside opening, that's usually mucus. Anything that's encapsulated inside, it's going to be serous fluid. All right, good. And what's the purpose of that serous fluid in the pericardium? To prevent friction. Prevent friction. Good, good. What's the thickest, most muscular part of the heart? Myocardium. Good, good, good. So would it be fair to say that the endocardium, or the innermost part of the heart, lines the chambers of the heart?
Yes.
Okay, good. What's the purpose of the endocardium? You folks remember?
To protect the organs.
To protect it as well, but what does blood usually do? What does blood do? Let me re-ask this again. If I cut my hand, what's blood gonna do eventually? Clot. So if you take blood and, like, let's say you had a lot of blood, right? And eventually the blood, if it's constantly pulling inside my hand, it's gonna clot, right? Right? Does that make sense? Because that's the tendency of blood. The endocardium has a surface layer that its properties allow it not to clot. So not only is it just the inside of the pump, but its surface area is made in such a way with such a material, the tissue, that it won't allow the blood to clot in there. Okay? All right. So it's made to prevent abnormal clotting. Does that make sense? Which is the big vein that brings blood to the right atrium, but from the lower part of the body? Inferior vena cava. Does that make sense? Now, which one brings the deoxygenated blood from the top? Superior. And it takes it to the atrium. Now, do you folks remember what the the portion of the outside of the heart. So you think about my hand as a heart, right? We have coronary artery supplying the outer surface or the actual heart muscle, right? Where does all that after it oxygenates the tissue? Where does that deoxygenated blood? How does it go back into the atrium?
Coronary sinus.
The coronary sinus. Okay, the coronary sinus. We talked about that in AMP. It's been a while. It's been a while, guys. Okay, what blood vessel or artery or vein takes blood from the lungs back to the heart? Pulmonary veins. Remember that in the heart, folks, it's reversed. The pulmonary veins have oxygenated blood. The pulmonary arteries that take blood from the right ventricle to the lungs, that's what it's called, the pulmonary artery. The blood there is deoxygenated. Okay? Let's see. You folks remember what the atrial natriuretic hormone or the atrial natriuretic peptide is? Okay, that's why I wanted to get a marker, guys. I feel like I'm handicapped without my marker. All right. Write down atrial natri or N-A-T-R-I.
What?
Natri, N-A-T-R-I. Uretic, U-R-E-T-I-C. So,
It's in the stomach.
peptide or hormone. However, you see it in the books, guys, you see it as both. As a peptide and as a hormone. It's a hormone, actually. So look, the atrial natriuretic peptide. What does this mean? Atrial, what's it referring to? The heart. What part of the heart?
Atrium.
So where is it found? The atrium of the heart. When I say natri or natri, what does N-A-T?
Nitrogen.
N-A. N-A. Sodium. Okay, so atrium of the heart, sodium, uretic. Urinary one, getting rid of fluids. Remember like a diuretic? Okay, so naturally, so it's atrium, heart.
So it gets rid of the sodium in the blood.
There you go. Natriuretic or natriuretic means sodium releasing or getting rid of peptide or hormone. This hormone, guys, remember how I kept instilling the RAA mechanism back in renal when we did the nephron? The renin, angiotensin, aldosterone. Okay, that brings up the blood pressure. But when does it stop? That atrial natriuretic peptide is what allows it to stop or to reverse its function. So, in the atrium of the heart, if the atrium of the heart is contracting too hard, or if it detects a high volume of fluid inside, it's going to release that hormone. And it's going to send a message to the kidneys. And it's called the atrial natriuretic peptide or hormone. And it tells the kidneys, hey, it's too much. So get rid of sodium so the fluid volume can go down, hence your blood pressure goes down. Does that make sense? Okay. So if I ask you guys, what's the purpose of the atrial natriuretic peptide?
To release sodium.
To release sodium, and in layman's terms, to bring down blood pressure. Okay? That's what it is. So where does my left ventricle pump blood to? Out to the body via the aorta. Okay? Via the aorta. Mind you, we can still talk about the aortic pulmonary valves. Okay, we can talk about that too, but where does the blood go after it leaves the right ventricle? Pulmonary artery, which goes to the lungs. Okay? Alright. There's a lot of questions like that, by the way. Like, the aorta pumps blood to what?
Outside of.
To the outside of the body. Yeah, that's right. Or like the right ventricle pumps blood through. You have to know them well. Technically, it goes from the right ventricle to the lungs, right? But it goes through a valve, and it also goes through what we call an artery. So this is how it goes: right atrium, okay, or excuse me, right ventricle, through the pulmonary. You can say the pulmonary semilunar valves or the pulmonary artery. Okay, then it goes to the lungs. Then it goes to the capillary system. Then it comes back via the pulmonary veins, now it's oxygenated. It goes into the left atrium, okay? It goes through the tricuspid valves down to the left ventricle, out the semilunar or pulmonary aortic valves, that's right, and then down to the body. So make sure, folks, you guys go back and you read all this stuff, okay?
Left is the bicuspid.
Left is the mitral valve. Yeah, you're right. Yeah, you're right. Okay. Why is the left ventricle of the heart thicker, the thickest? Because it pumps up for the distance, right? It has to pump all that blood to the body everywhere. What are the valves that are in between the atriums and the ventricles that open and close to release blood through those particular chambers? No. Listen one more time. Let me ask that again. What are the valves in between the atria and the ventricles? Atrioventricular valves, the AV valves. The ones on the right are called the tricuspid. The ones on the left are called the mitral or the bicuspid valves. Okay. Now, the AV valves, folks, you folks remember what the little strings are called that actually open and close them? The what? Chordinae tendineae. Yeah, chordinae tendineae. Good. So I'll ask you guys a few questions. Remember I talked about the semilunar valves? The semilunar valves, guys, are the flaps on the blood vessels inside the heart. Okay, not outside the heart, not the coronary arteries, but inside. We have two main blood vessels inside the heart. We have the pulmonary artery and the pulmonary and the aortic. The aortic one, right? Two big ones inside. Think of my arm as the pulmonary artery, right? This takes blood from the right ventricle, okay, to the lungs. Well, there's a flap in here that opens and closes at the bottom portion of it. Okay? What's the purpose of that flap?
To keep the blood from flowing back.
To keep the blood from backflowing, from going back up. Because imagine, it opens and it brings the blood up in here, and then it closes. If it doesn't close well, you have blood that leaks back inside. That causes issues. So the whole purpose of these valves, of these flaps, of the semilunar valves, are to prevent backflow to other chambers of the heart. It's a long test.
Yeah, how many questions is that?
I don't know, like 1,000. 70, I think. Look, folks, the way that they ask them, it's a lot of AMP questions, guys. Look, it's like this. If I talk about the aortic semilunar valve, what is the aortic semilunar valve receiving blood from? Where?
From the right
From
ventricle.
the right ventricle.
From the aortic semilunar valve. From the left. From the left ventricle, right? So once it goes, so it'll ask you like this, something like as basic as this. The blood goes from the aortic valve or the aortic semilunar valve to where?
To the body.
Outside of the
Out
heart.
to the aorta.
To the aorta out to the body. Like that, guys. A lot of questions like that. The blood goes from the pulmonary vein to where? To the lungs. Okay. To the left atrium. Yeah. But that's how the questions are being asked. Okay, guys. So in the book, it talks about the basic flow of the heart.
With the beginning of the chapter, you're gonna get a review.
Shh. What was that?
The beginning of the new chapter, you're gonna get a review again, right? Review.
Yeah, something like that. Yeah. And then she's gonna talk about diagnostic tests as well. What blood vessels take blood, oxygenated blood, to the heart itself? The coronary arteries. That's right. You guys have a question?
What was the question?
What takes? You're talking while you were heard. What vessels take oxygenated blood to the heart itself? You still don't know? I said it. The coronary arteries, guys. That's the blood vessels that fall on top of the heart. Does that make sense? All right. If I talk about systolic and diastolic, right? What does a systolic represent? The pump. What does diastolic represent? The relaxation. Okay. So if I ask you, what is what I'm about to talk about the systolic or the diastolic? The contraction of the chambers. The systolic, because it's contraction, right? The relaxation of the chambers. The diastolic. Good. So if a heart has one cardiac cycle, does it go through systolic, diastolic, or both? Both. Does that make sense, guys? Because it's one cardiac cycle, lub-dub. That's both of them. The lub and in between the little rest and the dub and the little rest. So it's both of them. Systolic, diastolic, that's a cardiac cycle, okay? When the heart contracts, guys, if the atria contracts, is it just one of them or both of them contracting at the same time?
Oh, one.
Both, guys. Both.
What's the question?
Let me ask it again. When the atria contract, is it just one atria or both atria?
Both.
It's both. The both atria contracts and then both ventricles contract at the same time. It's wrong, meaning not wrong, but you do have some instances and when an atria contracts and the ventricle contracts as well. But then you're having dysrhythmias. It's not a good thing. It does happen, but it's just not a good thing. Okay, it's bad. They can lead to some type of cardiac failure. So when you have the lub-dub, it's lub-dub, lub-dub, lub-dub. Does that make sense? Okay. I see why you guys are laughing. Again, what initiates, folks? What initiates the heartbeat? The SA node, the sinoatrial node. Where is the sinoatrial node located? Inside the right atrium. In between, not in between. It's in the atria. It's in the right atrium. Okay? It's very close. It's very close sometimes to the to the superior vena cava, but it's also close to I'm thinking about the AV valves. I'm sorry. Just know that the SA node, guys, is in the atria, in the right atria. That's where it originates the cardiac signal. Do you folks remember, did I talk about the electrical conductions of the heart? All right, so write this stuff down, guys. Write this stuff down. You'll find it in the book, but you're getting it from me first. And listen to what I'm saying. It starts where? SA node, the sinoatrial node. It goes from the SA node to the AV node, the atrioventricular node. That's a little, think about it as a little knob in between the atria and the ventricles. It's a little knob. The electrical conduction goes from the SA node to the AV nodes. After that, where does it go through? No. The bundle of His. There's a network of little, not vessels, but think of them as like little cables. Okay, think of them as little cables that reside right before it actually splits. That's called the bundle of His. Then it breaks down into its right and left bundle branches. So let me go again. The SA node, the AV node, the bundle of His, and then the right and left bundle branches. Now the right and left bundle branches, guys, come down like this, and they stimulate the heart to contract as well. Now, once they come down, they go to the Purkinje fibers. Now the Purkinje fibers are probably the most important ones simply because they're embedded inside the cardiac tissue, which actually causes the contraction. You folks understand that when the heart beats, it's an electrical stimulation. You folks are aware of that, right? What allows that electrical conduction to occur? Electrolytes. Which one in particular? Potassium. That's why potassium, sodium too, hell, even calcium. But that's why potassium is so important. That's why we always look at the potassium levels, folks. So again, SA node, AV node, bundle of His, right and left bundle branches, Purkinje fibers. Okay? If you look at different books, you'll have SA node, the intraatrial nodes, and that's there too, but we're not talking about all that stuff. We're talking about the regular conduction of the heart. You folks know what the intraatrial nodes are? If you think about the SA node being in the right atrium, so what's making the left one beat? Well, there's another little one that goes all the way, it looks like it's doing this. Okay, it literally looks like it's doing this to the other chamber, and that's how it causes the left atrium to contract. And the Purkinje fibers go through both ventricles, so that's how they contract. Okay, does that make sense? But again, I'm gonna say it one more time. SA node, AV node, bundle of His, right and left bundle branches, Purkinje fibers. Okay? All right. Please know the correct blood flow, guys. I would say it, but I'd rather write it up there, but you guys don't let me get my marker. You want me to say it?
Yes.
Yeah, I'll just, no. You guys are recording me, so I'll say it. The blood comes from, deoxygenated blood comes from the inferior superior vena cava. They enter the right atrium. They pass through the tricuspid valves. They go inside the right ventricle. After that, the right ventricle shunts blood through the semilunar valves of the pulmonary artery. The pulmonary artery takes blood to the lungs. They get oxygenated. Now it's oxygenated, right? It comes back via the pulmonary veins. Note how in pulmonary veins they're oxygenated now. It comes inside the left atrium. It passes through the bicuspid or the mitral valve, and it goes into the left ventricle. After the left ventricle, it goes through the semilunar valves or the aortic valves, okay, through the aortic arch, down through the aorta. Now mind you folks, when you talk about the aorta, depending on where it's at, it's going to be called that. There's something called the abdominal aorta because it's that segment that's by the stomach. And then it becomes distributed all over the body. If you guys know that, just how I said it, you should be fine. Okay? So if I ask you guys which part of those fibers, remember the SA-AV node, are responsible for making the ventricles contract? Which ones? Is it the SA node? No, because that's where it starts, right?
No, the AV.
The AV is way between the atrium and the ventricles. It's going to be primarily your right, left, and your Purkinje fibers. Your right, left, bundle branches, and your Purkinje fibers. Okay? The right, left bundle branches, the Purkinje fibers, and also the bundle of His. The bundle of His. So that whole segment, bundle of His, right and left, Purkinje fibers, that's responsible for making the ventricles contract. What's responsible for making the atrius contract? The SA node, the AV node, and the intra-atrial node that I haven't talked about that you don't have to know. But that's what's going to be it. Okay? You folks remember the difference between stroke volume and cardiac output? Okay, stroke is a stroke. One pump. That's a stroke. That's stroke volume, meaning the volume of blood being ejected out of the heart in one heartbeat, and one lump up. Does that make sense? Now, cardiac output is how much volume is being pumped in 1 minute. So you'll have several strokes. Does that make sense? Please know the difference. They will test you on this. So stroke is one pump. Cardiac output is 1 minute. Okay? We're almost done, guys. Please know the role of the hypothalamus and the medulla. Okay, please know only one of them are really responsible for heartbeats. Okay? But please know the role of those two, the medulla and the hypothalamus. Medulla and the hypothalamus. I see some of you guys not writing stuff down and chit-chatting. I hope you guys are recording me or something. Also, Ms. Lee will talk about this tomorrow as well, the role of the parasympathetic nervous system versus the sympathetic nervous system. Okay? The parasympathetic nervous system and the sympathetic nervous system. When it comes to the heart.
Well, the sympathetic system.
The sympathetic nervous system and the parasympathetic nervous systems. Okay, here we go. All right, so I had forgotten what it was. So when I talk about the parasympathetic system, guys, I want you guys to put down rest and digest, meaning it's responsible for resting and digesting. Now, I'll ask you the question in just a bit. Again, parasympathetic, rest and digest. The sympathetic system is responsible for the complete opposite, your fight or flight. Okay, your fight or flight. So now, with that being mentioned, what happens during your fight or flight? Adrenaline, right? So what's your heart rate gonna do? It's gonna go up, right? So while you're resting and digesting, what does your heart rate do? It goes down. Okay, it goes down. If everything's functioning normally, if we eat a big steak and then our heart rate goes up, that's not good. Okay, it's not supposed to be happening like that. So remember that, folks. The parasympathetic nervous system is rest and digest. The sympathetic is fight or flight. So which of those two nervous systems is responsible for increasing the heart rate?
Sympathetic.
The sympathetic. Which one's responsible for decreasing the heart rate?
I thought it was the other way around.
What was that?
I thought it was the other way around.
No. The parasympathetic is rest and digest. You guys see me Googling something, so you think I got it wrong, huh? Yeah. Look it up, guys. Look it up. If I'm wrong, I'm sorry, but I'm not. Alright, what does the vagus nerve do? What happens when it's stimulated too long?
So knock you out.
It will knock you out, yeah, you'll pass out. But why? What happens to your heart rate?
Goes down.
It goes down. Remember when I talked about digital extraction of fecal matter? Okay, you don't want to stimulate the rectum for too long because it creates pressure in the vagus nerve and it brings down the heart rate. That's why also sometimes when patients have like supraventricular tachycardia or some type of abnormally high heart rate, a non-invasive mechanism that they utilize is they tell you to bear down. The Valsalva's maneuver. And if you bear down, what are you also clenching? Your rectum. Okay, if you're pushing down, so that stimulates the vagal nerve, which therefore brings down the heart rate, or it's supposed to bring down the heart rate. Okay, does that make sense? All right. Also, another thing that they do, this is also nice to know, on your jugular veins, you have these receptors, and you have vagal nerve endings right there as well. We also do this, we do a vagal rub, and we rub the you-know-what out of that particular area. The problem is, most people that have heart issues, unless they're congenital, they're older, we're probably a little heavy, and what are our veins and arteries filled up? Fat and cholesterol. So what happens when we rub it? It breaks apart, and you might develop some type of embolism. Okay, so we don't like to do that too often anymore. So please know the vagus nerve, okay, guys? We'll also be talking about presoreceptors. Okay, what do you think they detect? Presoreceptors. Pressure, yeah. And chemoreceptors. What are chemoreceptors? We talked about this. CO2, right? CO2. So presoreceptors, guys, detect the blood pressure. Okay, and the chemoreceptors detect your CO2, deals with your respirations.